Welcome to the KTPH Hospital Renal Medicine Rotation. I am your senior consultant guide for this 18-minute clinical survival course. Nephrology is often seen as complex, but our goal is to demystify it and bridge the gap between theory and ward skills. You are an integral part of our multidisciplinary team, working with residents and our nephrology trainees every day. We expect you to be active learners. Participate in clinical rounds, shadow our residents, and contribute to patient care as a junior team member. First, we'll cover the recognition and staging of both acute kidney injury and chronic kidney disease. We will also dive into the management of electrolyte disorders and the core principles of dialysis. Finally, we'll ensure you're confident in safe renal prescribing, which is a critical skill in our wards. Nephrology is logical and systematic. If you approach it step by step, you will do well on this rotation. Let's begin with CKD essentials. We'll spend the next 3 minutes detailing definition and staging. CKD is defined by kidney damage or decreased GFR for over 3 months, staged by the KDIGO criteria. Stages G1 and G2 represent normal or mildly decreased function, often requiring monitoring rather than intervention. G3A and G3B represent mild to moderate and moderate to severe decreases, where complication risks start to rise. G4 is a severe decrease, while G5 indicates kidney failure, where we begin preparing for renal replacement therapy. Albuminuria A1 is normal to mildly increased. It's the baseline we aim for in our management goals. A2 represents moderately increased albuminuria, often the first sign of diabetic kidney disease. A3 is severely increased albuminuria, carrying a high risk of progression to end-stage renal disease. Screening is the cornerstone of early detection. Let's review the primary tools you'll use in the ward. Serum creatinine and eGFR are your primary blood tests to monitor a patient's filtration capacity. The humble urine dipstick remains a powerful bedside tool for detecting early protein and blood leakage. UFEMI provides critical microscopic detail, helping you identify active sediment like red cell or granular casts. UACR is our preferred ratio for diabetic patients, providing a standardized measure of albumin excretion. UPCR is used when we need to measure total protein excretion, often in non-diabetic glomerular diseases. Identifying high-risk groups is essential for early intervention and preventing disease progression. Singapore has one of the world's highest rates of diabetes, making it the leading cause of kidney failure here. Uncontrolled hypertension is the second leading cause, often causing silent damage over many years. There is a strong bidirectional link between heart and kidney disease. Always check the kidneys in your cardiac patients. When you encounter a newly diagnosed CKD patient, follow a systematic clinical approach for the best outcome. The most important step is to trend the creatinine. Is this a stable CKD or an acute on chronic decline? Perform a thorough medication review, looking for over-the-counter supplements and potential nephrotoxins. Assess volume status clinically. Check the JVP, look for peripheral edema, and auscultate the lung bases. Identify and immediately stop any nephrotoxins. NSAIDs are particularly dangerous and must be avoided. Our core long-term goals are BP below 130/80, tight glycemic control, and optimized renal protection. Next, we'll spend 2.5 minutes on common CKD complications, MBD and anemia. CKD MBD begins with phosphate retention as the kidney's excretion capacity falls. This phosphate retention triggers a secondary rise in PTH, leading to long-term bone disease. Management starts with dietary phosphate restriction. Patients should avoid high-phosphate foods like dairy and nuts. Phosphate binders help limit absorption, while activated vitamin D manages the secondary hyperparathyroidism. Anemia of CKD is primarily driven by the kidney's inability to produce enough erythropoietin. We target a hemoglobin of 10 to 12. We use ESAs and iron repletion to minimize transfusion needs. Always ensure adequate iron stores before escalating ESA therapy to ensure a proper erythropoietic response. Untreated anemia leads to severe fatigue, cardiac stress, and a significant reduction in the patient's quality of life. We minimize transfusions to prevent HLA sensitization, which is critical for patients awaiting a kidney transplant. Managing these complications effectively requires an integrated approach to diet, medication, and close monitoring. Let's turn to hemodialysis. We'll spend the next 3 minutes on principles and vascular access. Diffusion is the movement of solutes across a membrane down their concentration gradient, clearing toxins like urea. Ultrafiltration uses pressure to pull excess water out of the blood, helping us manage the patient's fluid balance. Convection, or solvent drag, helps remove larger molecules that diffusion alone cannot clear effectively. We aim for the patient's dry weight at the end of each session, the weight at which they are normovolemic. Standard dosing is typically 3 times a week for 4 hours each. We monitor adequacy using KT/V. We look for a KT/V of at least 1.2 or a urea reduction ratio of over 65% for adequate clearance. The arteriovenous fistula is our preferred vascular access. It's durable and has the lowest risk of infection. Protect the fistula arm. Never use it for blood pressure readings or venipuncture to avoid damaging the access. Tunneled catheters carry high risks of bloodstream infections and clots. We use them only when absolutely necessary. Watch for common intradialytic complications like cramps, hypertension, and site-related infections during your rounds. Hypertension during dialysis, or IDH, is often due to rapid fluid removal. It requires careful dry weight adjustment. Next, we'll spend 2 minutes on peritoneal dialysis, a home-based therapy that offers unique advantages. PD uses the peritoneal membrane itself to clear toxins and fluid, providing a more continuous form of therapy. The home-based nature of PD offers patients significant flexibility and a better overall quality of life. Importantly, PD is excellent at preserving residual renal function compared to traditional hemodialysis. Patients can choose between CAPD, which is manual, or APD, which uses a cycler machine during the night. PD peritonitis is the most feared complication. Always educate patients to watch for cloudy dialysate and pain. Cloudy fluid is peritonitis until proven otherwise. These patients need immediate medical review and antibiotics. Meticulous care of the PD catheter exit site is essential for preventing infections and ensuring therapy longevity. Let's look at glomerular diseases. We'll spend 90 seconds on the 2 main clinical syndromes. Nephrotic syndrome is characterized by heavy proteinuria, low serum albumin, and significant peripheral swelling. These patients are also at high risk for hyperlipidemia and have a significant prothrombotic state. Nephritic syndrome typically involves hematuria, hypertension, and a more acute rise in creatinine. Your role is to check for active sediment on urine microscopy, looking specifically for red blood cell casts. Accurate diagnosis starts with simple bedside tests, the urine dipstick, and careful microscopic examination. Next, we'll cover transplant pearls. We'll spend 1 minute on fever and rising creatinine in these patients. Renal transplant patients are complex. Any clinical change warrants an immediate call to the nephrology team. In these patients, even a small rise in serum creatinine is significant. Always consider rejection or infection first. Always consider the quartet: infection, rejection, obstruction, or toxicity from their immunosuppressant medications. Never ignore a fever. It is a medical emergency in a transplant recipient requiring immediate evaluation. Finally, we'll wrap up with some practical student survival tips for your rotation here at KTPH. Student survival tips: never prescribe NSAIDs. They are dangerous for any patient with renal impairment. Also, avoid pethidine and baclofen in advanced CKD, as they can lead to severe neurotoxicity. And remember, avoid routine blood tests immediately after hemodialysis. Wait for equilibration to occur first. Nephrology is logical and systematic. If you approach it step by step, you will do well. Welcome to the team.